right, I think we're going to get started here. If everyone would like to take a seat, please. So we are now to the early childhood mental health and the perinatal period portion of our afternoon, where we will welcome Dr. Katie Lingras, faculty of the University of Minnesota Department of Psychiatry, to discuss promoting early childhood mental health considerations for the perinatal period.
All right, good afternoon, everybody. Can everybody hear me okay? Okay, great. So I am fortunate to come after several wonderful people who've kind of introduced some of these ideas to you all. So I'm going to go a little bit more in depth about some of the things that you've already heard earlier this afternoon, and really thinking about kind of what are the building blocks that we're looking for in that perinatal period when we're thinking about early childhood mental health. So first, I want to talk a little bit about what do we mean by that idea of infant and early childhood mental health. And then I'll talk just for a couple of minutes about something to be thinking about all the way through the time today about how we think about culture and context and what that means for our understanding about early childhood mental health. I'll also talk a little bit about monitoring and acting early, sort of what to look for, those red flags, and what we can do when we see those red flags. And then finally, we'll finish up with talking about how to support the parent or caregiver in fostering resilience and that positive development that we want to be seeing during that early childhood period. So when we think about early childhood mental health, we're really talking about kind of three main categories of skills and behaviors. So first of all, forming those close and secure relationships, then thinking about how young children develop the skills to experience, express, and regulate their emotions, and along with that, their behavior. And then exploring the environment and learning. So how do we come to gain more skills, and how we learn and develop is largely through that exploration of the environment. And all of this is going on in the context of a family, of community, cultural expectations, and kind of the context that a child is growing up in. So you might hear some of these terms talked about as social emotional development, and we often use that interchangeably with early childhood mental health. So for just a couple of thoughts in terms of considering context and culture, we know that the environment that children are raised in really matters in terms of building those relationships with adults and caregivers, and that those relationships subsequently have a big impact on young children's cognitive and emotional and social development. So you may have seen this idea of the iceberg concept of culture, and I'm going to just spend a couple minutes talking about this idea here in case you haven't. So like an iceberg, we know that a lot of culture is really underneath the surface. We see kind of a tiny little bit of it above the surface, and we usually think about things like different types of food or celebrations, sometimes language or music, things like that. But we know that there's a lot of other characteristics about culture that are related that are not necessarily as obvious at first glance. And so a lot of these things are actually also really related to child development and how we think about early childhood and mental health. So you can see among the many items listed there that we see things like the nature of friendships, nonverbal interactions or expectations, the expectations for how emotions are expressed, attitudes about child development or about adolescence. All of those things are informed by a person's culture or background. And so we also can think about all of those concepts as influencing how we understand child development. And so that being kind of a factor of a bunch of different combined identities that any individual person or family shares. And so keeping in mind that our expectations about early childhood development, all of those interactions between families, within families, and understanding and expectations about mental health are really influenced not only by that cultural background, but by our own experience within a family or within our upbringing. And so we think about those things largely because there's a lot of variation. So even within any given culture, there's obviously a lot of variation from one family to another. And so we want to consider also how our own views and our own upbringing might affect how we as providers and clinicians can understand what's going on in a family, understand mental health, and how any of our own views might shape how we see a child's development, parent-child interactions, things like that. And the goal here isn't necessarily to solve and resolve every single bias or view that we might realize that we have, but just simply to reflect on it, to think about it, and to consider how that might be impacting our perception here. So when we think about kind of all the different topics I'm going to be talking about today related to early childhood mental health, I'll just encourage you to keep that in mind and think about your own upbringing, your own experiences, maybe even your own parenting experiences, and how that might impact your views about early childhood mental health. So on the one side of that triangle, we have relationships. And we know that nurture early on in life, we've heard this lots of times today in lots of different ways, is really important in terms of later development, both cognitively, socially, and emotionally. So when we think about attachment, we know that that's kind of that mutual, strong, and lasting emotional bond between a child and their primary caregiver and other significant adults in their lives. And we're looking for that caregiver to be responding to a child's needs for food and warmth and attention, comfort, any kinds of emotions that they're expressing. And as we heard earlier, it's not necessarily every single time that we're responding to every single overture, every single need, but over time that a child is learning that if I have a need, somebody's going to respond and that need will get met. And we know that these relationships that children are building, attachment bonds, are really, really important in terms of buffering against stress or adverse experiences that might come up during a child's early development. So when we're thinking about these early childhood experiences with relationships with a caregiver, we're looking for a few key different things. We're looking for that sensitivity. So how an adult is able to read the baby's cues and understand what is it that the child needs. What kind of cry is it? Are they hungry? Are they tired? Do they need to be changed? And we're also looking for them to respond at the right time. So most of you, I think, were here this morning when we saw the still face video. So I'm not going to show that again, but it's always encouraging to me when we're kind of all zeroing in on the same ideas here. And so when we saw this idea this morning, this video of the mother who just stopped kind of responding, had a flat affect face, and her baby got really distressed and started to kind of question what's going on here. We also saw that as soon as mom started to respond again, then the baby was able to re-regulate and they were able to kind of continue that interaction. So we're looking for those types of back and forth responses. So when the baby points, mom looks and maybe smiles, maybe says, oh, that's a ball. And then the baby does something else and laughs or points at something else, and then mom responds again or parent responds again. And so we're looking for these kind of continuous back and forth responses that are actually going to be really critical in terms of brain development and later cognition and development as well. And we're also looking for that social referencing piece. So again, thinking back to that idea of circle of security, we're looking for babies to be going out and exploring and starting to learn more about their environment and interacting with different things that they're presented with every day. But they're also going to be looking back to their caregivers to see, is this okay? Is this something that I should be exploring? Is this safe? Is this potentially fun? Or is it something dangerous? And so we can think about these ideas in sort of the psychology experiment context with the visual cliff experiment, where basically babies were put on a platform that then had a plexiglass surface. And so to them, it looked like there was just a cliff. There wasn't anything there. And what the studies showed were that if a caregiver were across on the other side of this cliff, and the caregiver was looking excited and encouraging and saying, it's okay, come on, come over here, the baby would crawl across what seemed to be a cliff that they might have fallen through otherwise. But if the parent were across on the other side going, oh, I'm not sure, that's not safe, making kind of hesitant facial expressions or gestures, then the baby would get upset, they wouldn't crawl across. And so so babies are really looking to their caregivers to see, is it something I should explore? And sort of the more colloquial or common way to look at this is to think about anytime you've seen a toddler who's still kind of learning how to walk, running around or maybe toddling around, let's say at a party on a lawn, and they fall over. And if anyone has ever seen that happen, if you look at the baby and everyone says, oh my gosh, are you okay? What happens? Waterworks, right? But if the response instead is, oh, you're okay, you can get up, you're fine, then usually baby will just get up and keep walking around and no crying whatsoever, right? So they're really looking for that reaction to tell them, should I be worried about this or not? So secure attachment is really critical as well in a lot of different domains. And so we talked about kind of the exploration and learning about the environment. It's important in that sense to strengthen brain connections and cognitive development. It's also really important for managing emotions, exploring new environments, learning skills. And it becomes kind of the building blocks for later relationships. So we see that attachment is really kind of the building blocks for other peer relationships or friendships in early childhood. later on for early romantic relationships and later romantic relationships, and then ultimately relationships with one's own children, so in a parenting kind of context. So I'm going to show you just this little video here, and this is an example of, first of all, it's a child's book, so as someone talking about early childhood mental health, I thought it might be nice to have a little story break in the afternoon. But I also really love this book because it is a great example of what this kind of secure-based type of behavior looks like, and it's a great way to sort of conceptualize it from a young child's perspective also.
Pouch. When he was a brand new kangaroo, Joey lived in the pouch until one day he peeked out and saw the world and his mama smiling down at him. "Mama," said Joey, "I want to hop." He climbed out of the pouch and he took 2 hops to the tall grass. "Who are you?" "Bee." "Pouch," said Joey. But soon he wanted to hop again. He took 3 hops to a little hill. "Who are you?" "Rabbit." "Pouch," said Joey. But soon he wanted to hop again. He took 4 hops to the sandy hollow. "Who are you?" "Bird." "Pouch," said Joey. But soon he wanted to hop again. He took 5 hops to the pasture fence. "Who are you?" "Kangaroo." "Pouch," said the 2 kangaroos. "Wait," said Joey, "you are afraid of me too?" Then they hop, 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 hippity hop everywhere. "Pouch," said the mamas, "no thanks." All right. So the goal really is to get to that no thanks part, right? When they have that kind of pouch or that secure base to come back to, then they each time explore a little bit further and a little bit further. And then ultimately, as children grow up, they don't need that secure base to come back to every single time anymore. So one of the other things that we think about in terms of that early childhood mental health is emotion regulation. And so you might be familiar with the idea of temperament or kind of different personalities that are really present from birth. And we think about some different categories about temperament. I'm not going to spend a lot of time going through those categories, but mainly kind of want to highlight that there are actually lots of different dimensions of temperament that we can think of within any given category. So we can think about activity level or intensity of reaction. So are you kind of a mellow baby or child, or do you have more strong reactions, adaptability, things like that? And then ultimately what we really want to see in terms of that temperament is not necessarily any one type of temperament, but we're looking at what's called the goodness of fit between that child's temperament and their caregivers. So it doesn't necessarily mean that everything has to match and line up perfectly, but we want to be able to see that a parent is recognizing what their child's temperament is and kind of thinking about how that may or may not fit with their own. So if you have a child who's more kind of introverted, takes a while to warm up to new places, and you have a parent who's really outgoing, loves to go from one place to another, they might be saying, I'm tired of being stuck in the house all day. I need to get out. I'm going to go to the grocery store, and then we're going to go to the library, and then we're going to come home, and then we're going to go back out, and we're going to go to the park. And that child who's slow to warm up might still be back processing the first thing and having a really hard time with that one to another, right? Most kids would. But you can imagine that if a parent doesn't start to think about that and think about what kind of temperament their child has and is not able to sort of match activities and behavior towards that temperament, then that can create some challenges. We're also looking at emotional responses. So over the first year of life, we see lots of different types of emotions start to develop, crying and smiling kind of being the first couple. And then later on in the second half of the year, we see sadness, surprise, anger, and then kind of last in that first year is fear. And so again, we're looking for these types of emotions to start developing, and then we're also looking for the parent and caregiver to recognize the cues, recognize what those emotions are, and respond to those needs. And so the other thing that we can encourage caregivers to do and actually model for caregivers even is narrating those emotions. And so we often start talking about that
around 2 or 3 or 4, but we can actually even do that earlier. So the child isn't necessarily going to understand every single word that's being said, but we can start to give parents and caregivers kind of the practice of narrating those emotions. So even saying, you're hungry, you're crying because you're hungry, we're going to get you some milk right now, right? Kind of helps parents kind of thinking back earlier earlier this afternoon, helps them kind of mentalize and understand where their child is coming from, what they're feeling, and modeling for them what that language is that goes along with that feeling. And ultimately, these are kind of the building blocks to self-regulation. So the child's ability to gain control of their body, of their emotions, their attention, and kind of their response to it. So it's okay to feel all of these different emotions, but what do we do with it? How do we regulate ourselves? And that's really key in terms of early childhood mental health. And parent-child interactions are really critical to regulating those behaviors. So in young children and babies, we see parents helping to regulate children by soothing them. You might see them rubbing a child's back or bouncing them or things like that. And that evolves into later independent self-regulation skills. So we can also be coaching those skills again from really early on in those kind of building blocks. So in terms of that third side of the triangle, the learning and exploring and development component, we know that learning starts really early on in development. And in terms of brain development, there is a lot going on in that first year. You may have heard the statistic, nearly 80% of brain development occurs between that 0 and 3-year-old range. And that is absolutely true. There's a lot going on during that early infancy time and early childhood time, but our brains also continue to develop into our 20s. And this is a really important idea to talk about with parents, because the more that we talk about how important early childhood and infancy is, the more parents are hearing about it, which is great. But then it also can make parents feel like, if I brought my child in at 4 years old, I missed the boat. And I've actually had parents who come in and say, I know he's 4. Is it too late to help him? And in my mind, I'm going, 4 is fantastic. I'd much rather have him in here at 4 than 14, right? But this mom had heard about all of this brain development research and how 0 to 3 is so important and thought there was no hope for her 4-year-old. And so really thinking about how some of these things are perceived and thought about on the parent side. And then we can also think about how the interactions shape brain development. So we know that both genes and environmental experiences matter. And this is where we think about that serve and return type of response. So I'm going to give you just an example about language and kind of building language development in this video here. And this is an example from the Harvard Center for Developing Children.
The key to forming strong brain architecture is what's known as serve and return interaction with adults. In this developmental game, new neural connections form in the brain as young children instinctively serve through babbling, facial expressions, and gestures. And adults return the serve, responding in a very directed, meaningful way. It starts very early in life, when a baby coos and the adult interacts and directs the baby's attention to a face or hand. This interaction forms the foundation of brain architecture upon which all future development will be built. It helps create neural connections between all the different areas of the brain, building the emotional and cognitive skills children need in life. For example, here's how it works for literacy and language skills. When the baby sees an object, the adult says its name. This makes connections in the baby's brain between particular sounds and their corresponding objects. Later, adults show young children that those objects and sounds can also be represented by marks on a page. With continued support from adults, children then learn how to decipher writing and eventually to write themselves. Each stage builds on what came before. Ensuring that children have adult caregivers who consistently engage in serve and return interaction, beginning in infancy, builds a foundation in the brain for all the learning, behavior, and health that follow.
So you may have heard about this idea of the 30 million word gap, the idea that there's a big gap in terms of a big
the disparity in terms of income level, in terms of the number of words that a child is hearing when they're growing up in a low income context versus a more affluent context. And so I'm not going to spend a lot of time on that study, but one thing that I want to highlight from that is that despite those disparities, we know, first of all, that there's lots of reasons that that may happen. And when we think back on that culture and context and the situations that families are experiencing when they're growing up, when children are growing up in a low income context, you may have parents who are working 3 jobs. And so there's lots of factors that go into that. But what we do know as well is that across all of those income brackets, the quality of the words matter more than the quantity itself. So these conversational back and forth kind of turns are helpful to kids in terms of language development, regardless of what their context is that they're growing up in. And we can think about what that context, that conversation looks like in terms of different developmental stages. So we can see that conversation happening even from infancy. And we're not full sentences, of course, at that point, but we're talking about that back and forth, cooing and giggling and responding back and forth. Okay, so a few thoughts about red flags for development. So things that we want to be thinking about and looking for. First of all, we need to know what is typical in order to know what's not typical, right? So I'm not going to go through all of the domains that we're talking about here in terms of developmental milestones, but on the next slide will include a couple, and on the slides that you'll see posted are a couple of links to some really great resources that kind of detail in all of these different areas what to be looking for from 0 to 5 years old. So we're looking at cognition, language, adaptive functioning, physical and social emotional development, all of which are supported by those caregiver interactions. And again, it's really important to know what's typical so that we know how to facilitate and support that positive development, and also so we can help parents identify when something doesn't seem quite right or catch it ourselves. So again, these links here will take you to a couple of websites that have some really great resources. And so broadly, when we are looking for things that might be concerning, we're thinking about problems with relating, so withdrawal, negative reactions or interactions, problems with self-regulation like mood, activity level, aggression, sensory disturbances, and then things like developmental concerns or just kind of a general, I'm not sure exactly what's going on. There's just something seems to be a little bit off here. So what can we do when we see those red flags? So first of all, most of the work that you all are doing, and at least in the context here that we're thinking about in terms of perinatal mental health, we're working with the adults as our first patients, right? So not only kind of thinking about them as individuals, but thinking about their role as parents and how that caregiver mental health is impacting their parenting role as well as their sort of general functioning. So how does a depressed mother, for example, how does her social network look or her close relationships look? And how does that then ultimately impact the child's experience from day to day? And what is the child seeing when that caregiver is struggling? So if mom's crying a lot or having a lot of trouble regulating her own emotions, what is the child witnessing during all of that? And that can be something that's relevant and present even from young children, even from infants who don't necessarily have the words or understanding to explain that. And then we talked earlier about parents' own kind of mental health history in terms of trauma and ghosts and angels in the nursery. So I'm not going to get into that. I will thank my colleagues for covering that earlier and saving me a couple minutes. And then the last thing we want to think about is in terms of when we're thinking about early childhood mental health is how we support that parent. So again, partnering with the parents for resources, kind of starting where they are. So if they're having trouble just day to day with their own functioning, not jumping obviously to the child's concerns, but maybe presenting that later. Supporting their own treatment, connecting them with resources, supporting that social network. We heard earlier about that power of the group context, and that can be really critical, whether it's in a therapeutic group or just an outside kind of social neighborhood network. And then really sustaining a climate of hope. So especially for the babies, when parents are coming in and they're struggling themselves, it's really often hard for parents to think about what is this doing to my child? What am I doing in terms of my own functioning and how is that going to impact my child? So letting them know we've got lots we can do here. We've got lots of ways we can help you and provide resources. And your visits themselves are a resource. So thinking about how to kind of create an emotionally safe environment, both for the young children if they're present and for the parents, because that's modeling for the parents. They may not have had that experience before, and it's hard to do something you haven't ever experienced yourself. Developing those strong and trusting relationships
giving caregivers an experience of consistency and predictability. Again, that's something we want to see for young children, but it's really hard to do if you haven't experienced that yourself. So providing that structure, even just by the visits, can be really helpful to parents in terms of creating their own routines with their babies. And then helping those caregivers catch those problems that they may not be aware of or they may not know what to look for. And finally, really helping parents to think about their child's development. So again, either using those resources that I shared about developmental milestones, or just thinking about what does their behavior mean. So if they are experiencing some troubles or struggles with their child, what kinds of behaviors are happening and what might that be telling us as providers, telling them as caregivers? And how can we understand what that behavior is telling us about what the children need? So just a quick review. We talked today about defining and understanding kind of the different domains of early childhood mental health, those three sides of the triangle, the monitoring for typical and atypical development, knowing what to look for in terms of red flags, and what to do when we see those red flags. So I think we have a couple minutes for questions. So if you don't have a chance to ask your questions today, I'm also including my information here. Feel free to email me, or if you'd like more information about our early childhood program in psychiatry. Thank you.
Any questions at all?
Thank you.
All right. Thank you, Dr. Lingras. So lastly, we're going to move to our clinical subtopic portion of our symposium. Our first speaker in this section is Dr. Cresta Jones. She's faculty in the University of Minnesota Department of Obstetrics, Gynecology, and Women's Health, who will be presenting opioid use disorders in the perinatal period.
All right, so I want to thank you guys for inviting me today. This is a topic that takes about 8 hours to comprehensively review, so I apologize if it seems like I'm kind of rushing or glossing over some of the specifics. I will have hopefully a few minutes for questions at the end, and also you can feel free to reach out to me. So first of all, I have no disclosures for today, and all of the treatments for opioid use disorders in pregnancy are not FDA approved for those specific indications. So I want to really briefly talk about just an overview of where we are in the United States with regards to opioid use disorders in pregnancy, or more specifically in Minnesota, to talk about the pregnancy complications that we see at an increasing frequency in these women, the recommended treatments in sort of very a brief overview, and some of the obstacles that we see to providing really optimal care for women who are struggling with opioid use disorders. And then I just want to put up a couple slides of resources for those of you who are interested in considering further information on this topic. So just briefly, we all know the opioid crisis is a significant issue in the United States, and the rates of overdose deaths have increased really dramatically over the last 10 years. When we look specifically at Minnesota, we're not immune to this crisis. Total opioid-related deaths have more than doubled in the last 10 years. And when we look at the women that we're going to be seeing, women who are being admitted for treatment or looking at treatment, this is data from the state of Minnesota looking at people who present for treatment in Minnesota and what are their identified primary drug of choice. And so this is for all comers, women and men, pregnant, non-pregnant. And you can see that in the last several years, opioids has really taken over as the primary drug of choice for which women are, or for which people are seeking treatment. Even more scary and not a topic of my talk today is the rapid rise in methamphetamine, which had peaked in about 2004, 2005, had a drastic reduction and is coming back. So it's just something to pay attention to as well. So this is a graphic that I did, kind of taking that data and looking at Minnesota women who are admitted to treatment, identifying opioids as their primary drug of choice. The green is all women, and the blue is that subset of women who are pregnant at the time that they enter treatment. So you can see over the last 5 or 6 years, the number of women seeking treatment has increased. And when you take out that blue subsection, you can see that although it is a small component of women seeking treatment, the rates are on the rise. So this is something that you're going to see in your psychiatry clinic. We're going to see in our pregnancy clinics as well. So the biggest issues with pregnancy and opioid use disorders are the conflicting interests. So we want to do what is the best as psychiatrists and obstetricians for the long-term health of our patient. Our goals are what is going to help them live the most productive and healthy life possible. But that may not be minimizing infant complications. And in fact, the recommended treatment for a mother, although it will reduce the risk of OB complications, will likely increase immediate neonatal complications in the form of neonatal abstinence syndrome. So that is sometimes a difficult thing to get a handle on. And in addition, in the United States, the social context does not promote disclosure for women who are pregnant. So there's substantial stigma from substance abuse. There are still a large portion of society which sees this as a lack of strength or a choice on the mother's part. Individuals or many organizations still have trouble understanding that opioid use disorder is a chronic medical disorder, much like hypertension and diabetes. And even in this state, we see the use of criminalization of this medical disorder. So instead of helping women get resources to do better, we criminalize their inability to remain in recovery. So this is just a brief slide looking at the most common complications that we see in pregnancy related to opioid use disorder. The most common maternal complications are infections such as HIV, hepatitis B and C, tuberculosis, and other sexually transmitted infections as well. Injury and overdose are significant concerns, and of course, maternal death due to overdose. The fetal and neonatal complications, the top three that I've listed, are all significantly improved when a woman engages in prenatal care and or treatment for her opioid use disorder. And the preterm birth statistic is pretty striking. So this is the data for the state of Minnesota over the past several years. Preterm birth rate in women struggling with untreated opioid use disorder, 1 in 4 women will experience a preterm birth, contrasted with 11% for the general population in the state. So certainly this is a big economic driver as far as improving outcomes. So that rate drops dramatically when women engage in treatment. So why do we treat women in pregnancy? We want to prevent opioid withdrawal symptoms, prevent complications that we talked about that could happen associated with non-medical use. And really we want to engage them in prenatal care and addiction treatment so that we can improve not only their obstetric outcomes, but their long-term health as well. And we talked about the reduction in OB complications also. So really, when we look at treatment in pregnancy, there's two options. Either you're helping a mother with what's called MAT or medication-assisted therapy using the options that are listed there. Some are preferred over others. We'll talk briefly about that. Or you are detoxifying a woman, either kind of letting her withdraw without assistance, using some sort of wean, with an ultimate goal for her of abstinence during the pregnancy. So the two recommended treatments for opioid use disorder in pregnancy are both medication-assisted treatments, methadone and buprenorphine. And I don't have enough time to kind of go over the pluses and minuses of each of these, but it's certainly important to note that they are individualized and you have to take a specific patient into consideration, the other meds she's on, her medical complications, what treatments has she failed before, how chaotic is the rest of her life when you're looking at this. So it's not a simple this group of women gets this and this group of women gets another treatment. Some of the things that we focus on in the OB community, and I've highlighted the red ones that are kind of drivers for what we do. For methadone, there's a much higher retention, at least in the randomized control studies that have been done in pregnancy with methadone treatment. We have a long-standing infant safety data because this medication has been around and used in pregnancy for many, many years. Whereas with buprenorphine, you need to have a mother who's in some level of withdrawal before starting it. For methadone, you do not. And so that complicates things in pregnancy. There's increased diversion for some patient populations. But buprenorphine in general has a shorter duration of neonatal abstinence. So babies are in the hospital longer or shorter. They require less amounts of treatment. So those are certainly different things that we think about. I want to talk a little bit about the alternatives because you may have patients coming into your clinics or patients that you're treating who either become pregnant or interested in pregnancy, and just sort of going over why these alternatives are not considered standard of care. So suboxone is the most commonly prescribed buprenorphine formulation for opioid use disorder in the United States. The naloxone is added as an antagonist to decrease diversion. There is minimal absorption with correct use, although there have been some recent case reports that there have been naloxone levels detected in cord blood. So we traditionally or classically been trained that moms took this medication and it did not cross the placenta because of the way that it isn't absorbed. But in fact, that may not be true. There are theoretical concerns for fetal development with the combination therapy. So that's really why. It's not that there's been a proven harm. We just don't know. So this is often preferred. So there are some states where their MA or Medicaid preferentially funds suboxone or combination therapy and not pure buprenorphine or buprenorphine monotherapy, mostly because of diversion risk. But there are several large opioid use disorder treatment and pregnancy programs throughout the country that are now using exclusively suboxone. So we will see more data emerging from this. Studies so far show very similar outcomes for moms and babies. So medically assisted withdrawal is something that we do not recommend, but there are many motivated women who come to me and say, I just want to get off of this medication. Most of them, we have a discussion and they end up remaining on treatment because their decisions are based on stigma rather than really what's best for them. But this has been used in very controlled and supported studies with about a 56% success rate. Now, what is defined as success in all of these studies is no illicit use at delivery. So it doesn't look at how many women relapse after their pregnancy, how many women stay in recovery for longer periods of time. So I think you need to keep that in mind when someone comes to you and says, this is a great option for pregnancy. And there's really no long-term outcomes on infants as well. In order for this to succeed, it takes extremely intensive inpatient and outpatient therapy. So there are patients that I have seen be successful with this, but it's certainly not what we recommend for first line. ACOG, which is the American College of OBGYN, provides practice guidelines for us as obstetricians. And they do say that medically assisted withdrawal is an option if women simply are unwilling or unable to proceed with methadone or buprenorphine. The important thing is there's no clear evidence of an association between medically supervised withdrawal and fetal death or preterm delivery. So if women are slowly weaned in a controlled setting, this may not increase the risk of obstetric outcomes, but again, we worry about the relapse rates. So naltrexone is an opioid antagonist. I'm sure you've all heard of it, described as Vivitrol. So this is a pure antagonist that patients may be placed on if they are completely weaned off of their opioids or their medication-assisted therapy to prevent overdose or sort of getting the euphoria they would get from opioid misuse. The biggest concern with naltrexone is that we just simply have no evidence in what effects this has on the developing fetus or on the newborn and breastfeeding. There are significant implications for post-delivery pain management because it is an opioid antagonist. Managing pain at cesarean section can be extremely challenging. There is a pregnancy registry, so if you do have patients who become pregnant on Vivitrol and are unwilling to transition to something else, it's important to get them involved. And the SAMHSA guidelines, and I'll talk a little bit about those at the end, the newest released last month from the federal government says that there really is no expert consensus on this and that there may be certain patients with appropriate counseling that you would consider using or continuing naltrexone for. Naloxone, the medication we use to treat women who have overdoses, is recommended for women who are pregnant. No, we don't have very good data on the safety of naloxone, but we have overwhelming data on what happens to someone who's overdosed when they're not given naloxone. So clearly the benefits outweigh the risks for utilizing this in women who have potentially lethal overdoses. The important things if you're encountering this woman in the community or in a health environment is to make sure that the uterus is displaced to allow better perfusion. So either tilting her or having just someone move the uterus, doesn't even really need to be the left side, but off of the great vessels. And they have recommended experts that we use the smallest effective dose, which would be 400 micrograms every 4 minutes as contrasted to the 800 that's typically used. I would argue that in this community with the extremely potent synthetic opioids that we have, I would probably still start with 800 micrograms to give you the maximum chance of good outcome for the patient. So I just want to talk really quickly about some of the issues that we see as OBs specifically related to this and some of the things that we can partner with our psychiatric colleagues on. So substance use screening, it is recommended that the first time a woman comes in for pregnancy care that we do universal screening because in the United States, approximately 13% of women of childbearing age report illicit drug use. This includes non-medical, but prescription opioids, alcohol, cocaine, methamphetamine, but about 13% of those women report use in the last year. The biggest thing is to make sure that it's non-judgmental. And in this state with the mandatory reporting requirements, this can be a little bit difficult. And basically, I phrase it to a woman saying, you know what, I want to have a healthy baby, a healthy you, and I can't do that if I don't know what's going on in your life and can't understand what medications I might need to take good care of you. But certainly thinking about the ramifications if a woman does report use, you sort of need to think that out before you have this conversation. But every woman that walks into my office for her first prenatal visit should be asked about these issues. I've always used the 4Ps plus, mostly because I don't have a very good memory and it's really easy to remember. So this is one that has been validated not only for alcohol, but other substance use in pregnancy. There are many other screening tools. I would simply recommend that you find one that works for you and utilize that in your clinic. And I think a lot of you, when you're taking a psychiatric history, are getting this information anyway. A significant number of women who have opioid use disorder that we see in pregnancy also have dual diagnosis. So again, my psychiatric colleagues are very familiar with this because you're seeing these women in your clinic. And often they're treating an undiagnosed mental illness with substances. So again, making sure that we know, instead of saying, why are you using these drugs? Why don't you care about your baby? What happened to you that you have found yourself here needing treatment, unable to access care, et cetera? Counseling, there isn't a specific type of technique that's been validated. What I've found successful for my women is to talk through really imagining the triggers that are going to come up in their pregnancy for relapse. How are they going to respond? And how can we build safeguards in place to avoid some of those situations? We know that neonatal abstinence can be more severe in women that are on other psychotropic medications, so antidepressants, benzodiazepines, gabapentin. But we also know that untreated mental illness increases the risk of adverse pregnancy outcomes. So I would argue, at least with my patients, that I would rather accept a well-treated mom who's not at a higher risk of postpartum depression and psychosis, who will adequately parent her child, as we talked about it with the last presenter, and accept a small increased risk in the length and severity of neonatal abstinence, which can be adequately handled in the newborn period. So we do not recommend that women come off their psychiatric meds in pregnancy, nor do we recommend it to help reduce the risk of NAS. I've had several patients who've sort of seen things on the internet and said, oh, I have to get off my Prozac because it's going to cause a higher risk of NAS. So I think that's kind of important. Tobacco use, really interesting. So about all pregnant women coming to a clinic, about 16% of them will be tobacco users. And almost half of them are able to quit spontaneously. This is just sort of cold turkey, if you will. 85 to 90% of women in medication-assisted therapy, and this is the only group that we have good data on right now, very few of them will quit spontaneously, but 90% of them will come in with some element of tobacco use, whether that's vaping or cigarettes or what have you. There is one relatively well-done study that shows women who are heavy tobacco users, if they're able to get down under a half pack a day, that there's an improvement in fetal growth. And one of the big things we see in medication-assisted therapy is poor fetal growth. And it is believed that some of this, when women are stable in treatment, is probably related to heavy tobacco use. So I tell women, I know you have a lot going on. I'm not going to tell you to quit smoking and stop doing this and be stable in your methadone all at one time while you're also pregnant. But I talk to them about how they can help their baby by gradually cutting down on the amount of cigarettes that they're using, with a long-term goal of abstinence maybe after the baby is born. Incentive-based treatment has been found to be very effective as well. So there's a wonderful program in Wisconsin called First Breath, where women enroll, and if they either cut down or quit during pregnancy, they get small gifts for themselves and their babies. So that's kind of a neat idea as far as looking at ways to improve our outcomes. So I think managing expectations, this is a group of women who live with a lot of uncertainty and chaos in their life. And if you can talk them through what's going to happen, it makes a huge difference in how those women do in the long term. So I'm going to just talk a little bit about all of those expectations that I kind of go over with them when they come for a consult. So I think the biggest thing is communication, and communication is very challenging because of the federal laws on confidentiality related to alcohol and drug abuse. So you need written informed consent. You need explicit description of what substance use disorders you're going to talk about. There's a time frame. And so it's important to make sure that you're cognizant that those specific requirements are part of the care. But I talk a lot to the patients about, okay, you come in to see me. Who are you seeing for your psychiatric care? Who are you seeing as your methadone clinic? We're going to sign all of these disclosures today. You're going to sign them for a year with me. I want to specifically be able to talk to them. And then I call and make sure that I establish those relationships. Patients do so much better if you get that. Otherwise, you talk to them, they say, oh, yeah, my counselor said this, or, oh, yeah, I'm going to go do this, or, oh, they fired me because I didn't show up for a visit, or my medication was stolen. And often, something has happened, they've relapsed and they're embarrassed and they don't want to tell you, but they often know that there's a good chance that we're not going to be communicating. And I think to really try and make the best efforts to have us all be one team is extremely important for their success. So for delivery, I think something that's very scary for women, they think that they are not going to get to stay on their methadone or buprenorphine, and that they aren't going to get adequate pain relief because there's this stigma that, well, your medication will cover your pain, or you're just drug seeking, you need to suffer because you have this chronic medical illness. So we really make sure we talk them through, you will get adequate pain medication. You will need higher doses than someone who's not on treatment, but you won't need longer doses. So we talk about having a lockbox, having some support person who knows they're going home with a prescription, having them know that I'm going to call their addiction program and say, hey, I'm sending her home with 20 Percocet, just so you know. And just those kinds of things are very important. Adequate education of staff on the terminology. Babies aren't born addicted. Babies can't have addiction. Babies are born with a physical dependence. Just some of those phrase words that I've seen really trip up my patients. Something simple that I tell every patient. When your baby is in the hospital longer because of abstinence, and on average they're in the hospital for about 14 days, does everybody in your family know why your baby's there? If not, do you have a good story for why your baby's there? Because when you're posting on Instagram that your baby's still in the NICU at day of life 10, and your baby was born on your due date, how are you going to answer to the people that are that call you out? And there is still this stigma with a lot of patients' family. And I've seen patients relapse because they run into somebody and this whole, conversation starts and they feel guilty all over again. So I think that's something that we can really talk through with them in the clinics. Breastfeeding is encouraged for women who are stable in recovery and do not have either HIV or hepatitis C with bleeding nipples. And that once if there's cracked and bleeding nipples and they heal, we encourage breastfeeding again. We talk a lot about birth control because 80% of women in treatment programs have unplanned pregnancies, and this is our opportunity to offer them options to empower when they choose to have that next baby. So I just want to talk really briefly about the legal obligations and challenges that we have, both in Minnesota and in the United States as a whole. There's a conflict in the philosophy of care when we're caring for a woman who is pregnant, because our medical model is that if we treat women, it's going to reduce substance abuse and substance use in pregnancy. And the law enforcement policies, which are evolving, but still overwhelmingly, it's that criminal punishment deters substance use. So if we incarcerate women, or we have fines, or we take their babies away, that will get them to get better. And we don't do that for a woman who has diabetes, who doesn't take her insulin. So I would argue that we need to sort of wrap our heads around what is the right thing and how do we reconcile that with our law enforcement colleagues. So the medical experts say, in 2017, the American Society of Addiction Medicine and ACOG said, we oppose criminalizing and other punitive approaches to substance use in pregnancy. Likewise, the American Academy of Addiction Psychiatry also opposes punitive action or legislation that requires mandatory reporting of illegal substances in pregnancy. So I will read you the Minnesota statute section. A person is mandated to report if a person knows or has reason to believe that a woman is pregnant and has used a controlled substance for a non-medical purpose, including but not limited to, and I'm not exactly sure, having only lived here for 7 months, why this carve-out was initiated, but THC and alcohol you don't have to report. There is an exemption for prenatal care providers for THC and alcohol, but not for anything else. And likewise, the local welfare agencies can seek an emergency or involuntary admission if a pregnant woman refuses recommended voluntary treatment or fails recommended treatment. And what is defined? What defines recommended treatment? How do you decide a woman has failed? But I think this is important for you to know what the construct is for our care in this state. And in the statute, they also decline neglect of a fetus or child as prenatal exposure to a controlled substance. So this is a woman who is struggling with a clinical illness and is being defined as a neglectful parent. I will argue that mandatory reporting undermines patient-provider relationships. It's not to say we don't want to report women when we think they're a danger to themselves or others. But when we have this just for opioid use or other substance use disorders, it's really inconsistently treating chronic diseases. Again, if a woman has uncontrolled diabetes or doesn't take her blood pressure meds, we don't call Child Protective Services. And it really does, women do avoid care, and there are very good legal articles on states that have mandatory reporting and mandatory treatment for women who test positive on urine drug screens that women don't stop using, but more women present in labor with untreated substance use disorders. And universal urine drug screening without some type of conversation with the patient about why it's being done and what can happen bypasses a conversation and doesn't allow you to collaborate with this patient to make her healthy and to make her a better mom. So for any of you that are interested in this, I just want to bring up a couple of resources that have come up in the last year. So there are two outstanding publications, both unfortunately in the obstetric literature, on how we manage women in pregnancy, and also looking at the neonatal outcomes. One was the executive summary on opiate epidemic, which was a collaboration with the NIH, and the committee opinion, which is just a wonderful recommendation on how we should practice, and it's a collaboration between the American College of OBGYN and the American Society of Addiction Medicine. And then this wonderful link just came out last month, and this is a great resource, nice, easy to read language from the federal government, from SAMHSA, on treating pregnant women and parenting women with opioid use disorders. And we realize and acknowledge that a lot of what we do is not yet supported by well-designed studies and may never be. So this specific resource is great because it uses expert opinion. And although I'm very much in favor of evidence-based medicine, it's just not something that we yet have. So this is, I would strongly encourage all of you to take a look at this. It gives clinical situations and then sort of talks you through the issues related to them. So obviously this is a very serious public health concern. We all see this in our practice every day. The best thing is to get a woman into medication-assisted therapy with methadone or buprenorphine. We know that there are very specific issues related to treating these women when they become pregnant that need to be acknowledged and addressed. And I would point you all again towards those resources as a very helpful first start for all of us partnering in these women's care. So I will open up for a few minutes of questions. I also have my email on here if there are any questions that you have or patients, hypothetical issues to run by in the future. Thank you.
Hi, just in your experience, so what happens after a provider then reports that a woman is taking opioids in pregnancy? What's the typical course of action after that?
So that's a great question. And unfortunately, it is county dependent. So if you live in the metro area, the two counties that comprise the metro area have great resources. And I think that they do an outstanding job of contacting the woman and saying, I'm here to see what you need. Do you need help with housing stability? Do you need parenting? You know, trying to get women into really solid support for their recovery. In general, if they're early in their pregnancy and they are using illicitly, they're going to help get them into treatment. Once they're in treatment, they're going to have a much lower chance of their baby being taken away. But unfortunately, it's very county dependent, and a lot of that is what resources or what infrastructure does the county have to help the woman. My experience working in Hennepin is when we get women engaged in treatment, they're scared about what's going to happen when they're reached out to, but then they're very grateful once they actually talk to the organizations. But it's getting them past that stigma of, we're all going to advocate for you. I want you to keep your baby. I know you can be a good mom and you just need my medical help. So I need you to talk to this group to see what we can do to make it easier for you. All right. Thank you, you guys.
All right, next, it's my pleasure to introduce Dr. Emily Pisetsky, a co-founder of the Women's Wellbeing Program and faculty here at the University of Minnesota Department of Psychiatry, who will speak to eating disorders in the perinatal period.
All right, thank you, Katie, for that introduction, and thank you for inviting me to speak here today. So actually, when Katie invited me to speak, she said in all of her perinatal training, she hadn't gotten a lecture on eating disorders in the perinatal period, which I think is pretty concerning, and so I'm glad everybody is going to get exposure to this, and I'll talk to you about the numbers and why I think it's concerning. Don't talk more about this particular set of problems in the perinatal period. So today I'll be going through eating disorders as they relate to conception, pregnancy, birth outcomes of moms with eating disorders, how eating disorders manifest in the postpartum period, and then, of course, talking about how to assess and treat. So briefly, before I dive into this, we'll talk a little bit about the primary eating disorders that I'll be talking about today. Anorexia nervosa is a disorder characterized by the hallmark feature is a low BMI. There can be restricting subtype or binge purge subtype. This affects about 1% of women. Bulimia nervosa is a disorder characterized by binge eating and some sort of purging or compensatory behavior. That may be self-induced vomiting, laxative misuse, excessive exercise, or fasting. This affects about 3% of women over the lifetime. And then binge eating disorder, which is binge eating in the absence of compensatory behaviors, which affects about 5% of women over their lifetime. So we get about 8% prevalence of eating disorders. You'll see that what we know is actually most women don't fit one of these neat categories, so we actually see a higher prevalence of eating disorder not elsewhere specified. So I'm not going to get too specific about the diagnostic criteria for that reason. So what we know about eating disorders in conception is that as it relates to fertility and miscarriage within anorexia nervosa, we actually have no differences in rate of pregnancy, reported infertility, or infertility treatment in women with histories of anorexia. Women with histories of anorexia are more likely to see a fertility specialist. However, they're actually not any more likely to engage in fertility treatment. So what this indicates to me is that there may be more anxiety about their ability to get pregnant, but they actually are able to get pregnant without assistance. And one of the reasons I think these disorders are not talked about more often is because one of the former criteria for anorexia nervosa was amenorrhea. So we used to require that women not get their periods to be diagnosed. And what we know is actually you can conceive even when you're amenorrheic. However, many providers don't know that, but certainly many patients don't know that. And for that reason, we see women with anorexia are at twofold greater risk of unplanned pregnancy. And as we heard this morning, about 50% of pregnancies are unplanned. So when you get twice that, that's a pretty high rate. I actually, early in my training, worked with a woman who had had anorexia since she was 12 years old, had never menstruated in her life, and had 3 unplanned pregnancies. So she never reached a BMI over 18. So you can certainly see pregnancy in this population. With bulimia nervosa, we do see higher odds of taking more than 6 months to conceive and conceiving with the aid of fertility treatment. So here we actually see something slightly different than with anorexia. And we have a higher odds of twin birth, which is probably related to higher rates of fertility treatment in this population. They also have a higher risk of miscarriage. However, on the flip side, we do still see elevated risks of unplanned pregnancies in those with active bulimia nervosa compared to those with a history of bulimia nervosa or no eating disorder. And so here you will also see some disruption in menses in women with bulimia nervosa, and yet they're still able to get pregnant. With binge eating disorder, there is a greater risk of miscarriage. However, folks with binge eating disorder do often tend to be at a higher weight status, and it's hard to tease apart whether their trouble with fertility is related to higher weight status or whether it's related to the binge eating specifically. So the takeaway point from this is it's really important to discuss desire for having children and options for contraception in folks with eating disorders, even if they are not menstruating currently. And it's important to educate about the risk of pregnancy and prevention for unplanned pregnancy, again, even in the face of menstrual disturbance. So what happens to the eating disorder during the pregnancy? So as anybody here who works with these women or is being pregnant themselves know, as soon as you get pregnant, there's a huge focus on what you're eating, weight gain, your body shape, these messages come immediately, which for somebody who has struggled with an eating disorder can be quite challenging. In terms of how these folks react to pregnancy, women with an eating disorder are more likely to experience negative feelings upon discovering that they're pregnant. And these negative feelings can persist through 18 weeks gestation. So they really can have a hard time finding out that they're pregnant. And so being aware of that and sensitive to that. Some of the reasons why a study that looked at these reactions found they have kind of personal conflict, putting the fetus's needs above their desire to engage in the eating disorder, difficulties dealing with their feelings about their self-worth due to their body image, concerns about the child's health. So what is it going to mean that I have this eating disorder and now I'm pregnant? And worries about other people's responding to their eating disorder and their weight control behavior. So a theme that has come up today is there's a lot of stigma and shame around having psychiatric illness in the face of pregnancy, and particularly for somebody who's restricting or purging, they can face a lot of stigma around that. So again, what happens to the behaviors during pregnancy? So combined eating disorder samples found that between 29 and 78% of women with an eating disorder report remission of symptoms during pregnancy, including a decrease in weight and shape concerns, restrictive eating, and binging and purging symptoms. So that's good news. However, you can see that's a pretty wide confidence interval, or pretty wide range and confidence interval. So we do see some folks who go down in their eating disorder behavior. However, we do see a higher rate of relapse. So pregnancy can relapse or can trigger a relapse for women who are in recovery from their eating disorder. So about a third of women with a history of anorexia will experience a relapse once they get pregnant. And pregnancy can be a window of vulnerability for onset or continuation of binge eating disorder. So we do see onset of binge eating in pregnancy. Some of that is thought to be around increased nutritional needs, but also we hear that it's okay to eat more, and oh yeah, when you are pregnant, you need to eat ice cream, and that can be sort of normalized, and it can actually turn into eating disorder behaviors. So what happens in terms of weight gain for these women? So we do see greater gestational weight gain and faster rates of weight gain in women with an eating disorder compared to women without an eating disorder. Women recovered from anorexia prior to their pregnancy have lower gestational weight gain than women without an eating disorder. However, bulimia nervosa and binge eating disorder is associated with greater gestational weight gain. That's thought to be due to ongoing binge eating or decrease in purging. So if you're continuing to binge eat and you're no longer purging, that can be associated with weight gain. And women with binge eating who report greater worry over gestational weight gain actually are the ones who do end up gaining more weight. So if you see somebody who comes into the OB office and said, I'm really worried I'm going to gain weight due to my binge eating, they actually are at higher risk of greater gestational weight gain. And again, you see messages like this, think twice before you're eating for two. Some of this can be helpful to get information around what their caloric needs are. Some of this can be less helpful. So for somebody who has a history of anorexia, 1,800 calories a day is not what their starting baseline should be. They probably need to be at a higher caloric baseline. And so when they see things like this of, oh, in the first trimester, I should only be eating 1,800 calories, that's not necessarily the case for them. So being able to have those conversations about what are your caloric needs, your caloric needs are going to go up over the course of pregnancy, and they're actually going to go up quite a bit in the second and third trimester. So being able to have those kind of individualized conversations. And remembering that what is appropriate weight gain is going to vary based on where you're starting. So somebody who is starting at a lower weight is going to need to gain more weight, and that can be very hard for somebody with an eating disorder, both body image-wise and to increase their caloric intake that much. So getting some support and education around that. So in terms of treatment during pregnancy, as I mentioned, a lot of these pregnancies are going to be unplanned. And so making sure that you are screening for any weight control behaviors that they're engaging in, screening for other unhealthy behaviors such as alcohol, tobacco, non-suicidal self-injury, insulin misuse for anybody who has diabetes. They may be manipulating their insulin as a way of controlling their weight. And you want to have a really frank discussion around what the weighing process is going to be like. And so do they want to know their weight, or do they want to do blind weights? A lot of folks, when they go through eating disorder treatment, do blind weights because knowing that they're gaining can be so distressing. And so this may be something that you want to talk to your patient about. How are we going to handle this in a way that is conducive to your recovery? There is some risk of hyperemesis, so these patients may need more frequent visits with their OB team. Giving some psychoeducation around nausea and vomiting. Vomiting that is because you're nauseous and because you're having symptoms related to pregnancy is different than self-induced vomiting. And so really talking to them about that. These patients are at higher risk of GI discomfort and constipation, particularly folks who have misused laxatives in the past. Talking to them about what the GI discomfort will look like. Improving body awareness. There's a whole host of literature that folks with eating disorders have decreased body awareness and decreased somatosensory awareness. And so talking to them about that, what pregnancy is going to feel like, what they should be attuned to, what are symptoms that are normal in pregnancy and they shouldn't be over attuned to. And then signs and symptoms of preterm labor. So we'll see in a minute that these folks are at risk for preterm labor. So what are the things that they should be looking for? So some takeaways from this section related to pregnancy. You want to always sensitively address their reaction to pregnancy. So if this is the first time that you're meeting someone and they are pregnant, be aware that they may have some mixed feelings about that, or actually some quite negative feelings about that. You want to assess their eating disorder symptoms and collaboratively develop a plan. So how you're going to monitor your weight, how you're going to monitor nutrition, as well as psychological functioning. And then, as I mentioned earlier, some psychoed on nutrition needs and weight gain, and provide guidelines and recommendations that are really individually tailored. So what do the birth outcomes look like for the babies of these moms? So within anorexia nervosa, there's been kind of a wide variety of negative birth outcomes that have been observed. So they are at increased risk for preterm birth, C-sections, fetal growth restriction, low birth weight infants, small for gestational age infants, infants with microencephaly, infants with decreased APGAR score at 5 minutes, and greater risk of perinatal mortality. So that's not great, but hold on to that. Within bulimia nervosa, there is increased risk of fetal growth restriction, preterm labor again, anemia, GI tract infections, and labor induction. So again, that's not great. However, the larger population-based cohort studies have consistently demonstrated no significant differences in adverse perinatal outcomes in women with histories of an eating disorder. So not to get too into the weeds on the literature here and why we think that difference is, but most of the negative findings come from women who have been not only in treatment for their eating disorder, but often in a higher level of care. So these are often women who've been hospitalized for having an eating disorder, or intensive treatment. So those are the folks who get followed up more longer term. The larger population-based cohort studies are ones who maybe have never had treatment for an eating disorder, but did screen in sort of a national registry. The other thing is most of those population-based studies do come from Europe. They're mostly Scandinavian, where we do have more comprehensive wraparound healthcare. So that may be part of the reason why we don't see the differences there, whereas the top two bullet points came mostly from U.S. studies. In terms of binge eating disorder, there is a risk of maternal hypertension, low for gestational age infants, higher birth weight infants, increased risk of C-sections, and gestational diabetes. However, these women do tend to be at higher weight status, and it gets a little bit hard to tease apart what is due to the higher weight status and what's due to the binge eating. So then what happens to the eating disorder during the postpartum period? So as soon as you give birth, you are expected to magically lose all that weight and look like the model on the right, even though the model on the left probably wasn't actually pregnant. She was probably just pushing her stomach out a little bit. And again, these are images that they are going to see everywhere. They're going to go to the grocery store and be checking out, and there's that magazine of how celebrity lost all the weight really quickly, and if you just take this diet, you'll be able to lose the weight too. Which is really hard for all of our postpartum mamas to see, but anybody who has a history of an eating disorder or an active eating disorder, this is really tough to see as well. So what do we know about what happens to the weight status during the postpartum period? So as I mentioned, this time is really challenging due to their increased satisfaction with their weight and shape. And we do often see that eating disorder symptoms worsen during the postpartum period. And we see greater decreases in BMI over those first 6 months for women with all eating disorders. So anorexia, bulimia, binge eating, and eating disorder, not otherwise specified as the old term. In terms of breastfeeding, we don't see any differences in initiating breastfeeding, but we do see an increased risk of cessation of breastfeeding at 3 and 6 months postpartum. Some of the reasons why are insufficient milk supply. So if you're restricting your intake quite a bit, it can be hard to produce milk. Or even if they don't have insufficient milk supply, there can be a worry that they are and they're not feeding their baby adequately. Additionally, it can be really hard for these moms to expose themselves. There's a lot of body image and shame around exposure, and so that may be part of the reason why we see these women discontinue breastfeeding. And then I want to talk a little bit about how eating disorders overlap with perinatal mood and anxiety disorders, or PMADs. So I was glad to hear Crystal this morning say that eating disorders are a risk factor for PMADs. And what we see is that women with histories of all types of eating disorders do exhibit greater depressive and anxiety symptoms in the postpartum period compared to women with no history of an eating disorder. And the prevalence of postpartum depression in women with a history of an eating disorder is estimated to be 35% compared to 14% of women with no history of an eating disorder. So we see a much greater risk of postpartum depression in these women. And even if you think I work in a perinatal mood disorder clinic, I don't work with eating disorders, we see a lot of that, oh, those are tough disorders, we don't treat them. What we know is actually about a third of the women who come to your perinatal mood disorder clinic will have an active or a history of an eating disorder. And so that the Meltzer-Brody article is coming out of UNC's perinatal mood disorder clinic, or mentioned several times today. So again, they see high rates of eating disorders in that clinic as well. So how do we treat this? I actually had a slide in there earlier that I took out, which was who everybody should be involved, what the team should look like. We haven't spent as much time today talking about the team, so I want to make sure that I pause and bring that in. And one of the great joys to me about working in this field is all of the team-based care and interdisciplinary. So particularly for women with perinatal mood disorders, particularly women with eating disorders, getting the whole team talking and working together. So this could be your OB, the pediatrician, psychiatry, psychology, social work, dietitians should be involved, doulas can be involved, nursing partners. I had several other folks on there that now I forget, but that we really should have the whole team involved. In terms of what that treatment can look like, cognitive behavioral therapy is an evidence-based treatment for both eating disorders and PMADs. Interpersonal psychotherapy is an evidence-based treatment for both eating disorders and PMADs, so these are great places to start. Social support groups. We heard earlier talking about just the power of the group and the wonderful work that HCMC is doing. And whether it's support groups or psycho-ed groups, there are some curriculum that are being developed specifically for mothers with a history of an eating disorder. So how do they engage in that feeding process? That feeding process can just be so challenging for these moms. I don't have a video. I know we've seen many videos today, but when we videotape moms with a history of an eating disorder feeding their baby, that we see that flat affect. So where many moms will do sort of the choo-choo train or try to smile and engage baby, we see that flatness. And you've seen many times today what happens to babies when mom is flat, and that can make that feeding process all the more challenging. So psychoed and support around feeding particularly. Couples therapy is an evidence-based treatment for PMADs, and there's also more work of how to bring the partner into eating disorder treatment, so I think that's a lovely way to intervene. Sleep hygiene is really important, and how we get these moms sleeping and resting and taking care of themselves. Psychopharm, we heard a lot about that this morning. And nutrition, I really want all of my moms who have a history of an eating disorder working with a dietitian who is eating disorder informed around how to get adequate nutrition, what those nutritional needs are, and how they change over time. And then exercise is something we want to get these moms moving their body in a healthy way. So not going back to maybe the compulsive overexercising that they were engaging in, but how to get a healthful relationship with exercise. And that may be yoga, it may be cardio, whatever that looks like. But that can be really helpful. So a couple of takeaways from this section. So we want to continue to monitor eating disorder behaviors, their mood symptoms, and suicide risks. So you heard Crystal talk this morning about the risk of suicide in PMADs. And actually, eating disorders have the highest mortality rate of any psychiatric disorder. So these are folks who are really high risk for suicide, and we know that the postpartum period can be a really high rate risk time as well. So we want to be making sure that we're monitoring that and checking in. You want to assess their eating behaviors and their physical activity. Be open to addressing issues related to eating and weight and body image, that these can be challenging topics to talk about. And then I hopefully stressed before the importance of a collaborative team-based approach. But remember, you can't treat what you don't know about. So I was actually giving this talk for an eating disorder group about a month ago, and one of the women came up to me afterwards, who was 8 months pregnant, and shared that she had a history of an eating disorder, and her OB had never asked her if she'd ever had an eating disorder, and that had just not been part of their care, and that she felt like she really had to disclose that and say, hey, I have this eating disorder, is that going to be a problem? And so we really want to make sure that we are asking, and again, it can be really shameful for these women to admit that they are engaging in purging behaviors, or they're not eating they're not eating sort of enough calories. So we want to make sure that we're asking. A couple of screeners. The SCOFF is one of the main screeners that's used. You could see that this came from England, as the 1 stone doesn't translate quite so well, but other than that, so asking, do you ever make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost a significant amount of weight? The 1 stone is not so important, but have you lost weight in a 3-month period? Do you believe yourself to be fat when others say that you're too thin? Or would you say that food dominates your life? In general terms, 2 or more on this is concerning. However, I would say if a woman is endorsing any of these in the clinic, it's important to keep asking and addressing. The other main screener that's used is for primary care. So I know we have some OB/GYN colleagues and some family medicine colleagues here. So this is a screener that you can use. So are you satisfied with your eating patterns? Again, many pregnant and postpartum moms may say no to this. Doesn't mean they have an eating disorder, but it opens up the conversation. Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family suffered with an eating disorder? And then I got asked once, I only have time for one question. What is the one question I can ask? The one question is, do you currently suffer, or have you ever suffered in the past with an eating disorder? Even if you're just blunt and say, is this something you've struggled with? Folks will say yes. And again, at least you've made it okay for them. You've asked the question, show that you care about this and that you're willing to have the conversation. So again, I'm really glad that I was able to come here today and talk about this, because my goal is for us to break the cycle of risk and to get these moms in a better place, both for themselves and to make that feeding process and parenting a more nurturing process. So I really appreciate it and open it up to any questions.
I just wanted to clarify one slide. Did you say that women with a history of eating disorders are at a higher risk for hyperemesis?
Yes, I did say that. And I think I put that in the takeaway, and now I'm realizing I forgot to actually put the data for where that came from. But yes, they are at higher risk for hyperemesis. And I can get you a reference. I think in my shortening of this talk, I took away that data slide.
Do you know why that is?
It's a great question. The last time I gave this talk, I got asked the same question, and I deferred to our medical provider, who is not here for me to defer this question to. And so I actually don't know why that is. My guess is it has to do something with how much they have difficulty with GI tract and sort of feeding patterns in the past. That's really not medically based. That's a hypothesis. I'm not really sure. So I would love to hear if any of the medical providers have a better hypothesis or know the data. All right. Thank you.
Finally, Dr. Benita Dieperink, a mentor for this creation of the symposium, as well as a reproductive psychiatrist of the mother-baby program at HCMC and the HCMC Department of Psychiatry, will conclude our afternoon with a brief talk on mental health in the pregnant and postpartum woman, making sense of illness, treatment, and healing.
Good afternoon. This has just been such a pleasure. So just a few brief comments. First of all, as Katie said, Dr. Thorsness, this is just really, these are going to be some thoughts and really not a full talk. Just as we're winding up the afternoon, I thought maybe that would just be better. And really, I've been practicing for 20 years now, and it just, I think it was such a good challenge to try to distill like a fine sauce what kind of kernels I could try to offer this group, given that there's been so much information also that just important and wonderful today. I feel like some of what I would say is certainly also redundant. Other speakers today. So, and the other thing I wanted to mention is that this is a Prezi presentation where there's going to be some movement. I thought that might be good just at this stage in the afternoon, but if anybody struggles with motion sickness and is unhappy with this, just please let me know. So as I said, I've been doing this work along with our group at Hennepin for 20 years, which has been the great adventure of my professional life, and such a beautiful, with so many beautiful and unexpected experiences, and also very painful experiences as far as seeing families suffer. But to have a group to work with, to try to process, try to be well informed, try to help people access treatments has just been so powerful. And I just am so excited about what you are doing here at the U, and the way that you are arranging your group and your connections with other departments. I think it's going to be, it already is, and it's going to continue to be really fabulous. So I also just sharing a thought, which is that having done this now for a while, I used to have a feeling when I was walking down the hallway with a patient, helping her push her stroller, that feeling of, oh, this could be my baby. And now as I'm older, I realize somewhere it shifted. It wasn't a conscious shift, but I realize I'm helping with the stroller, feeling like a proud grandmother, as my colleagues are walking down the hallway, like, look at our beautiful baby. And I really feel that way about your group, actually, that I'm just so proud of what you've done already this year. I can't believe it. So we are forging a path into an era of precision healthcare for the childbearing family. This family, the family at this tender stage, is greatly affected both by nature and nurture, age-old questions, but it really crystallizes here in a way that is challenging and very rewarding for all of us as caregivers, bringing our different skills and perspectives. So the challenge to us really is to discern effective treatments and deliver them in a timely way. And then, as Dr. Vinogradov was saying, also to be able to loop back and reflect, like, how is this working? That it's really a co-created process with the families who we're serving. We are learning in leaps and bounds about the how and why of mental health crises in the childbearing years of a woman's life. We are growing more aware of the importance of recognizing families in pain. Healing the family at this stage is a huge opportunity for positive impact. Upstream care, meaning that it's really primary prevention in many ways, that we reduce suffering, both physical and emotional, to family members. Starting, of course, in our case, with a woman identified as our patient, but really, again, as many people have said, the ripples go out to the entire family, also the extended family, others in the community, to help a woman be well as a mother. So on this path also, I just wanted to mention, again, this part of it, I would even say selfishly in a way might be for ourselves, to more deeply understand our humanity and also our biology, that bringing our full curiosity, full openness to exploring our own humanity, letting people express their humanity, and kind of discovering, what people want for their own lives. It's just one of the most rewarding parts of this whole work. And so, there's a child and adolescent psychiatrist. His name is Dan Siegel. He's written some very influential books. One is called Parenting from the Inside Out. More recently, as he's raising his own family, he wrote a book about teenagers called Brainstorm. But he has an institute at UCLA, which is very interdisciplinary, including philosophers, neuroimagers. He, of course, comes with a child and adolescent medical background, but they really have been meeting to talk about, what is our modern concept of the mind? This is an age-old question. The mind, we can't touch it, but we all know one. We don't know where it's located. What is it? And so this is really what they came up with. And I feel many presenters today have really been talking about this in terms of the co-creation, baby and parent, developing the sense of the child's mind, and also that the parent's mind is affected in this process. But so the idea here is, let's see if I can point to this one. Oops, no, that wasn't what I wanted. No. The idea is really that this is like a wheel. If we think about the outer rim, that, as long as that's intact, everything is rolling pretty smoothly. And the spokes between the central part, which is the mind, kind of the internal sense of things. But you have your five senses, your physical perceptions, also that our brains are always picking up stimuli from inside our bodies. We're picking up, the vibe in the room. Our brains are constantly processing a ton of information, all of which feeds into our own sense inside ourselves of the reality of how things are. And so again, if some of those spokes are breaking, the wheel starts hobbling along and the mind is unsteady. This is a classic drawing, Netter. I loved him in medical school. He was an artist who went to medical school. I don't know how clearly you can see this. And actually, Katie, can I ask you, is the pointer up here? Okay, I just don't want to, I don't want to make the slides go haywire again. But anyway, so this is really going into the brainstem, kind of the ancient part of our brains we share with, everybody else who's got a nervous system, basically, that's developed. This very large nerve goes through the neck and directly to all of our major organs. So this is really evidence for a very direct connection between the mind and the body. And I think, we all do well to think more comprehensively and integratively about things, also to help our patients feel integrated. This is actually a study, 2014, fairly recent, from the Proceedings of the National Academy of Sciences, which is as hardcore science as you can get often. But this study really showed patterns analyzing many people's physical response to different emotions. They had different standardized tests that they offered people. So it's pretty cool. Body maps showing, again, like these are emotions. And I actually really loved this phrase from the paper, which said, emotions coordinate our behavior and physiologic states during survival salient events and pleasurable interactions. It's really an organizing function of the brain. It has a purpose. Rather than, there were very nice presentations, I think, again, about people's experiencing, helping to help people not feel broken, to really understand, this is happening, and what kind of information can we get from it to help you. And this last slide, this again is from the Mindsight Institute, but I think this is so important that we often talk about the brain or even the mind in isolation because it feels like it's kind of our mind. But again, this work helps us see so much that our minds are really they're social organs where we are interacting not only with the environment but other people, and also is very important in terms of much of the emerging science around neuroplasticity, even in adults, the fact that we can change brain structure and function even in grown adults, people my age, which I'm very encouraged by. So we as healthcare professionals can be most helpful if we are also integrated. And I hear so much of that in this conference. I'm just so heartened by it. So across specialties and disciplines, then our work is around the care of women and their families. And together we can ask, how do we effectively heal biological imbalance? How do we offer behavioral treatment in a way that feels healing to a suffering person? What can we learn about systemic environmental dysfunction that may be revealed as distress in families? We, like any other creatures, are affected by our social and physical environment. And disintegration, what does this mean? How can we start to understand this? What have we learned so far about these questions? This is from the Adverse Childhood Experiences study that Jesse Kundig was mentioning, and I think this slide is just so helpful. It's a visual also that really adverse childhood events are like or just like a stain spreading over people's lives, over their life course, in terms of all the suffering that causes in body and mind. I think that's the other important thing about this slide, is that both mental and physical disorders, really up to early death, very clearly have been shown to be related to high incidence of adverse childhood events. This slide, this is a little murky here, but basically these are Black women, white, and then Hispanic, showing the disparities in low birth weight children to Black women is huge compared with women who aren't Black. And that should give us pause again in terms of social conditions and what, even though somebody may get the same prenatal care, there's actually a very nice article published by a Black African-American neonatal doctor and a white neonatal doctor really looking at the differences in prevalences in the NICU, and showing also that for women who are African-American, are well-educated, are living in, upper middle-class suburbs, that the rates of preterm delivery are still higher. That again, really looking at systemic racism as a health risk, even if somebody isn't there economically, that again, that sense of really trauma held in the body that may be historical even through generations is something that we are, I think, really starting to have a look at in science. And this slide, just to show, this is, I think, a very active area of query in the most biological journals in psychiatry, rethinking our diagnostic structures. This from the National Institute of Mental Health, the research domain criteria, probably many of you have heard about this, but I again think this initiative is so interesting and much more realistic than what we have been using. Where we are revisiting how we define and describe mental health and illness. And now these research domains include genomics, circuits, behavior, and interestingly, self-reports. I thought that was great in terms of, cross-checking it with what do people feel like inside themselves. And this again to explore the basic dimensions of functioning that span the full range of human behavior from normal to abnormal. So this, just a brief slide, recent information about routine healthcare for perinatal women. We're really not doing very well in terms of full remission. Identification actually in many of these studies was very, very good. We've come a long way through some collaborative initiatives. I think that where screening for depression in OB clinics, family medicine clinics, prenatal care is really being emphasized, and providers are very diligently trying to do it. But in terms of really connecting that screening with appropriate treatment, we're really not there yet. The screening rates were 30 to 50%, which I thought was impressive. higher than it used to be. These are data from the Mother-Baby Day Hospital at HCMC, and Jesse showed this slide, really emphasizing that there is a very, great discrepancy in terms of the CDC Kaiser study looking at ACEs in women in our population and the study population versus the Mother-Baby Day Hospital moms who have 4 or more. This is sort of a cutoff point where ACEs become really significant. It's, there's somewhat of a linear curve, but the curve really accelerates here. And this, again, just to highlight diagnoses, thinking again more about dysregulation. I'm sure in the presentation this morning by Postpartum Support International, Pregnancy Postpartum Support Minnesota, there was a discussion of the importance of PMADs, that we really have tried to broaden the whole conversation. It had been very much focused on postpartum depression, which was great as a first step, but also limiting. I've had women say to me, well, I'm not depressed, so I must not have anything, when actually they're anxious or they have OCD. So really broadening the idea of, anything that might present at another time in a woman's life can also present postpartum or be worse than postpartum. Certainly the experience of it, the context of it, the biology of it can be very different. And that we're learning a lot more about in terms of the research. So frontiers. Reproductive psychiatry research is very much main stage in medical journals these days, which is very exciting. Psychiatrists from the Netherlands who run a psychiatry unit dedicated solely to care for women with postpartum psychosis. It's a catchment area for really all of Northern Europe. They published an article in the American Journal of Psychiatry about their work, which really studied not only the phenomenology of postpartum psychosis, but also they were looking at nervous system markers, inflammatory markers, very comprehensive. This paper was selected as one of the top 15 most important medical articles by the editors of the New England Journal of Medicine that year, which was 2016. Dr. Robert Friedman, you may be familiar with his name. He's the editor-in-chief of the American Journal of Psychiatry, which is arguably the most prestigious journal in psychiatry. He gave a keynote address recently at the leading perinatal mental health meeting about his research into the administration of choline antenatally as a potential way to reduce the population's risk for schizophrenia. So again, just thinking about frontiers, I thought that would be a nice way to end our afternoon. So this, again, this pyramid, Jesse showed that, and also the expanded pyramid looking at urban ACEs, but it's been known that rates of early death are elevated for many years based on the ACEs research, adverse childhood experiences, but the mechanism of this really hasn't been clear, and probably there are many mechanisms, but interesting, these are chromosomes in the DNA, that contain the DNA, and the telomeres here, this is the part of the DNA that controls how long the cell will live, and really is associated, in aggregate, all of our cells is associated with how long we will live. And so interestingly, the telomeres have been shown to be substantially shortened in people who have high adverse childhood experiences. And on the positive side, I think this is positive for all of us who might be wanting to do this work and engage in this work, that telomeres are actually lengthened in adults who who are with a child at least once per week. So again, there's much reason to hope. Epigenetics, these are chemical signals really that directly interact with DNA to regulate how DNA will be expressed. And so we all have the same DNA, but clearly different things are expressed at different times by different cells. And this is one of the mechanisms for that. Anyway, this again, American Journal of Psychiatry, really our premier journal in general psychiatry, has this article, which I thought was quite something, looking at epigenetic programming, a putative mechanism, looking at childhood maltreatment, and at risk for adult psychopathology. And this is just a slide from the Harvard Center on the Developing Child, really detailing how epigenetics works, particularly related to the nervous system. Again, we're in an era where we can really start thinking about and working towards precision psychiatry for the perinatal woman. This is an app, a cell phone app, which is very accessible also for women in rural areas. This is a perennial problem. How do we get people, I mean, we have a hard enough time getting care to women in our urban areas. How do we even begin to help women who don't have access to medical care very easily? So anyway, this is part of the genome-wide association study looking at large numbers of people and their genes and symptomatology. This is very specific to perinatal symptomatology. So women can record the kinds of symptoms that they're having postpartum. They take a little swab of their cells from inside their cheek and they send it to the researchers in the United States. They are primarily located at the University of North Carolina. So that is really neat. And this is the article by the group, really spearheaded by the group in the Netherlands. This is the work by Dr. Friedman and Dr. Ross about choline, the supplement. This, there's a representative here today from Sage Therapeutics. This is a novel mechanism that researchers are looking at in the States and also internationally. Allopregnanolone is a natural hormone in our bodies. It's very difficult to give in pill form and has been very difficult to isolate or synthesize, but we're on the cusp of that now and looks very hopeful in terms of the treatment of postpartum depression. We really haven't done well. There have been some studies looking at hormonal intervention that seemed very natural in terms of postpartum depression where there's such a change in hormones, and we know that after a woman gives birth, but the results really haven't been good, and the medical complications potentially high, such as blood clots. So this is really, I think, going to be an important direction. And again, I'm sure that we'll find that different women have different risks for various different reasons. Some may be trauma, some may be a strong family history of bipolar illness, some may be a strong family history of sensitivity to changes in reproductive hormones. This is, again, where we will be zeroing in, again, to be much more quick in our ability to assess what all the contributors are and to respond appropriately with a bigger toolbox. Also, advocacy. Oh, I wanted to speak to this. I was so thrilled to meet one of the people involved with the Brain Connectome project today. And, you know, in terms of, again, looking at broadening our idea of how we can watch our own brains in action, looking at cognitive behavioral therapy and how does it impact what we're seeing on fMRI and PTSD and major depression. This could be very helpful in terms of, again, figuring out who's a good candidate for this. Neurofeedback, this is an interesting therapeutic direction really based on EEG readings. But again, I was very surprised to see this in our premier journal. And again, just really broadening the array of therapies that we have. It's very exciting. Advocacy, social justice, you know, we have several presenters today have mentioned that, and I mentioned earlier, again, racial disparity is very clear in terms of birth outcomes. I just wanted to mention a few things nationally and locally, mainly just to say also how hopeful this is. I think the passion that people have around this area of work, families who have suffered through perinatal mental health crisis, also researchers who are, and clinicians who can see the suffering that families go through, the motivation, the volunteerism, the self-organizing is enormous, not only nationally, but also internationally. Crystal and Samantha may have mentioned actually Postpartum Support International, which we are a state chapter of here. This organization has volunteer coordinators in 47 plus countries, all volunteer. Volunteer helplines. It's really impressive. This organization is transforming actually to really join with international organizations. This was a meeting where Dr. Friedman presented, and again, there's really a very active dialogue between families, people who are survivors, and professionals, where we're really informing each other and also developing priorities. So one priority has been the legal system. We are very out of step in this country. That women say who commit a crime while they commit a crime towards a newborn or infant or child, that they will first go into the penal system. They will go to legal consequences rather than, in most countries around the world, they would go into the medical system thinking before we would ever assume that this is criminal activity. We are going to rule out, particularly in a mother of a newborn, we are going to rule out medical illness. So again, We've had a fairly punitive stance, quite punitive. But so the first law has been passed in Illinois through advocacy, again, much hard work, collaborating with international colleagues to really start to become much more in step with international practice. This is also true for the mother-baby hospitals. This has been very much a standard of practice in the UK and UK-affiliated countries. And finally, we've been able to start to develop that here. Also locally, just in terms of Minneapolis, there's this really lovely project, the Itasca project. There are many Fortune 100 business leaders who are part of this group, realizing, we are not, we're really not doing well. I think I might be fading out here, but you can see that Minneapolis is third from the bottom in terms of our opportunity gap. And so these leaders are calling out the opportunity gaps, which are based on racial disparities and how they impact families in Minneapolis. So what this slide is about, it's maybe hard to read, is the proportion of workers earning a family sustaining wage by race and education, and really showing disparities, white and non-white. And then also Mill City Kids. This is, again, an organization that's really grassroots. Many people coming from different disciplines. Helen Kim participated in this very actively, Dr. Kim, from our program at HCMC, to look at education disparities and what we have to do about that in terms of, again, this is so wrong and we have to do something about it. So that is really all I have to offer. And it seems like we've all been digesting a lot of information. And maybe the questions will come later, but if you have questions, I'd be happy to take some. I'm so curious about who is in the room, maybe wondering about who are students, learners, who are nurses, who are working in OB, who are psychologists, who are social workers, who are physicians. And who did I miss? I'm sure I missed doulas, midwives, anybody. Anyway, I mean, what a beautiful, we were so hoping for this. I know you were, in terms of really using this as a chance to really bring people from the university and greater community together, from disciplines all connecting with childbearing families. So wonderful. So thank you.
Thank you, Dr. Dieperink. I think that was a lovely conclusion to our afternoon. So thank you, everybody, for coming on behalf of the Department of Psychiatry here and the Women's Wellbeing Program. It was so great to see everyone here today. Be on the lookout for a feedback form, as well as a link to all the slides that you saw today. We'll have access to that. And if you have any questions, I'll also include my email, too, about our program here or any other questions that you have. Thank you. At some point before the end of the year.
You have been